Welcome to the Academy of General Dentistry Podcast Series featuring Dr. George Schmidt. Each episode features experts in the field of dentistry who share insights and inspiration to help you succeed. Let's get started.
Welcome back, everyone. We've got a great show for you today as we're going to talk a little bit about dental sedation with my good friend, William Moorhead, affectionately known as BJ. Hey, BJ, how are you?
Good afternoon, George. Thanks so much for having me.
Yeah, really looking forward to this. This is going to be some great stuff to talk about. So a little bit about BJ. He has developed and teaches systems and strategies for treating high fear patients. With over 20 years experience in sedation dentistry, Dr. Moorhead teaches practical ways to make sedation safe and practical in your practice. Dr. Moorhead speaks across the United States on topics related to systems management, clinical efficiency, dental technology, medical emergencies, treating anxious patients, and leadership. He's also the founder and owner of StreamDent Software. Dr. Moorhead has served in many leadership roles, too many to list here, including president of the Kentucky Dental Association and many, many others. So I'm really excited to have you on the program here and looking forward to it. BJ, of course, cost is always an issue when it comes down to dentistry, but fear has been identified, if not the number one, then very close to being the number one reason that folks don't visit the dentist. And of course, we have ways that we can manage that with, behavior modification and psychology and all that. But sedation dentistry, as we know, is a tremendous way to add a service that is a great benefit for the patient and also transfers down to the bottom line. And that's, of course, what I wanted to talk to you about. So if you don't mind, just at the outset here, give me like the 30,000-foot view of why this is important to look into.
In dentistry, there are so few dentists that do IV sedation or any level of sedation. In 2016, the ADA changed the guidelines and made it more difficult to do oral sedation. You basically have to have the same certification in almost every state now. But there is, according to ADA statistics, something like 60 million adults that completely avoid going to the dentist. That's a huge market that we've left untapped. Oral surgeons have that market, but just for surgery. And I hope we know as general dentists that there's a lot more to do than surgery in dentistry, and that's not where we should be focusing.
Absolutely. So let me ask you a question, just sort of set the stage here. So talk to me about the difference between the types of sedation. Of course, we have oral sedation, that may be some Xanax or something like that, and nitrous and so on and so forth. But then you have moderate sedation and deep sedation. And where are those boundaries?
Okay. Minimal sedation, almost every state a dentist can do without any special permit. As long as you can if you've got a DEA permit and can write a prescription, you can give a dose for, at the most, the manufacturer's recommended dose of a single drug. That's most state laws. And most states will also, because nitrous oxide is so easily titrated, will allow the dentist to add to that the nitrous oxide over and above the sedative that they choose, whether it's a triazolam, hydroxyzine, drugs like that. If you're going beyond the stage of taking away the edge of relaxing the patient to where the patient is going in and out of sleep, that is a quick, short definition of moderate sedation. And for that, it requires a moderate IV sedation permit. That's where most general dentists fit into that scheme. There is deep sedation where the patient is deep enough that you can have to breathe for them to keep going. Oral surgeons are all trained in that and in general anesthesia. A nurse anesthetist and anesthesiologist are all trained in deep anesthesia and general anesthesia. The difference between the deep and the general, in general, they are definitely going to intubate and they're going to put the patient to sleep. Deep sedation, if it's planned, often they will still intubate, but they won't be using the gases and the things that they use in the hospital operating room.
And, you mentioned state regulations, and I think it's important to point out here. Let's just spend a few minutes on that. You really can't, and most people know this, but it's worth mentioning that you really can't just go out there and start to do this. You've got to check with your state regulations to find out what training you need, right, for these different types of things.
And you better stay on top of them as well. Yes.
Yeah, that's really important. So, how would somebody do? So, I'm assuming, and we'll talk a little bit about. I know you do a lot of training and you have a great course, and we'll talk about that in a few minutes. And I'm sure you help folks with that. But for somebody that's curious to know whether, hey, is this something that I'm going to be able to do in my state, or does it make sense? Where do they look? Is there a website they can look on, or?
They need to go to their State Board of Dentistry website. Some of them are a little bit harder to dig out. I've got a, a dentist in Indiana that is taking our course now. He searched and I searched and contacted the state board, could not get any direct information. So, because of the limited funds and the limited people that state boards have, sometimes it's more difficult.
Yeah. And while we're on that subject of sort of deciding if this is something that might make sense, what about the physical plant, the physical space? I mean, do you need a larger footprint in your office for something like this, an area for a recovery, let's say, or can this all be done in the operatory? How does that work?
It can all be done in the operatory. All state regs pretty much have a minimum size operatory. I've most often seen at least 8 foot by 10 foot because it's got to be large enough that if there would be an emergency, that the EMTs can get their equipment in there and be able to help, plain and simple.
Yeah, so that's one of the things there. And of
On
course,
the recovery room, no, you don't have to have, as long as you can leave the patient in the operatory until they're properly recovered. But there are also regs that if you do transfer the patient to a recovery room, typically you must have suction, you must have the monitoring equipment. Uh, Most states require that you leave a dental personnel there. You don't want to park them with a relative and have no one supervising them that knows what to watch for.
that's a really good point that these folks should never be left unattended. And that goes for obviously making sure that they have the appropriate transportation and things like that as well, I would imagine.
Definitely have to have an escort. You don't want them driving home. Uh,
So,
I heard an incident, and this is 20 years ago that I heard this, where a escort got out of the car and went in to fill a prescription, and the patient that was out of it got in the driver's seat and drove off and had an accident. Um, so we insist when we dismiss a patient in our office that we document that we seat belted them in and the escort signs something that agrees that they will go directly home.
yeah, so you said incident, and that's a great segue to one of the things I wanted to talk to you about. So I'll throw that out right here right now. Because when we hear about sedation, oftentimes we hear about all the bad things, right? And we read about it and maybe a patient death and things like that. So what can you say to somebody that might be looking to take some of this kind of training, but they read that and they get a little skittish, if you would, and say, I don't think that's going to be for me. I mean, do you have anything you can speak to about that?
To the dentist we're talking about, right?
Yeah, the dentist, yeah.
Well, I can speak to that because I did that for years. Uh, let's cut back. I got interested in treating fearful patients in the first place because when I was a child, I had a dentist work on me back in the early 60s that I have lots of allergies, and the medical training then wasn't what it is today. And the GP dentist told my parents it wasn't safe to numb me up because I had lots of allergies. And so I sat there having deep things done on first permanent molars with no anesthetic. So I know dental fear. Flip side, I learned to be fearful of other things in medicine, like having blood drawn. So the idea of me starting an IV on a patient, I put off for years, even though I was doing oral sedation, because when it's me, I was transferring that fear on my end. If it were me starting the IV, it is quite different, by the way. Um, so that's a natural fear that was of mine, at least. It's kind of a comical one. But there's also the fear that I hear out of a lot of general dentists that that's too complicated. I don't want to have to to add all that complexity, but yes, you have more to learn. But once you have it mastered, and you've mastered a lot of things, you have capabilities. Once you have it mastered, it makes treating these fearful patients so much easier. I mean, you know the things that you have to deal with the gagging, with the can't get numb, with the broken appointments. It takes so many problems away.
Yeah. So, BJ, I've got to ask you this because I've done a number of cases in my office, many cases in my office with sedation, but I've always brought the anesthesiologist in. And I always marveled at the amount of time that he actually spent sort of monitoring the situation, monitoring the patient. And I scratched my head a couple of times and I said to myself, if I were to try to do all this at one time, I don't know if I could do it. I mean, is that a common occurrence? And, how does that all work?
Fair question. I'm going to use an analogy before I directly answer the question. Um, when you are not doing sedation, are you pretty used to multitasking and having to go from room to room and hygiene checks and numb up a patient here and go back and forth there?
I would say I
Good
think we
guess.
all are. Sure.
Okay.
Yeah.
Okay, sure. Uh, with sedation, moderate sedation, you're not going to leave the room. You're not going to be allowed to. That's going to limit your focus. With that said, you're used to multitasking, and the patient is always breathing. There's always a monitor that's doing the proper beeping and warning you over there. We're required in almost all states now to record vital signs, and there's software that can do it automatically every 5 minutes. So I can almost all the time do IV sedation with what my Kentucky regs will allow, with just my dental assistant and me in the room. There's other people in the office that I can call, and we've got a radio on to be able to communicate. That's my choice. Um, they're not required in most states, but a pretracheal stethoscope can always let you be listening to the patient all the time, even if they don't breathe in and out through their nose, where capnography will work. That's just almost foolproof.
One of the things, and I think you just touched upon it, one of the things I wanted to ask you was, are you bringing any additional auxiliary staff, like an RN or anything like that? Or do we need to have that?
I don't. In my state in Kentucky and only a handful of states, we are allowed to send a team member to learn how to start IVs. But if the dentist starts their own IVs, um, and you've got to dispense your own medications, got to manage those things. Um, but unless you can always have the extra people in there, it's according to how the individual dentist likes to practice. And some states do require at least one extra person be in there to do nothing but monitoring. And that can be a dental assistant. Some states require that there be a course for the dental assistant to be certified in monitoring IV sedation. West Virginia, for instance.
Yeah, so that's really good advice. So I guess it really circles back to the thing we started off with. You really got to be aware of the state regulations, and I'm sure once you get the proper training, you'd be aware of that. So speaking of training, let's talk a little bit about that. And I know you have a company that provides really great IV sedation training with AGD's own Darren Greenwell, and you guys do a great job with that. So talk to me a little bit about how that works, about your program and things of that nature.
American Dental Association guidelines for moderate sedation require 60 hours of didactic training and 20 direct clinical experiences. That's how we have our course organized. We're based in Kentucky. We work out of Dr. Greenwell's office in Radcliffe, Kentucky. We designed a program where we can do a lot of the 60 didactic hours online. We'll do it face to face through Zoom, some videos to watch. We've got a portal. Our doctoral students like that we record everything so they can go back in that portal and rewatch videos. I've created all the handouts where they're searchable PDFs to make it easy for them to look up information and learn it and get reinforcement out of that. For those 20 clinical experiences, what we do is hands-on experience where the doctors are starting IVs, pushing their meds, monitoring the patients, doing the paperwork that's required for the anesthesia records, and doing some dentistry so they can get a feel on what it's like to work on a sedated patient as well, because it is different. One of the things I like about our course particularly is that Dr. Greenwell and I are both practicing dentists. A lot of programs are academic people, dental school faculty that are teaching, and they absolutely also have the credentials. But when they don't have the real world experience, it's difficult for them to help practitioners like you and me be able to take it to our office and be able to apply it. And the doctor checklist stuff that you mentioned, I thoroughly have documented how to document things and how to implement things. And I think it makes it much easier for the doctors that go through our program. And that's what I hear too.
Yeah, we'll talk about that in a few minutes, but you make so many great points because I think it's important from an educational standpoint when you have some practical experience, right? Didactic experience, fantastic, right? But you need that practical experience. And one of the things I like about what you're saying is not only are you and Dr. Greenwald both dentists and have great perspective, if you would, but what you're saying is you're allowed to do the dentistry on the patients while they're sedated when they're in your facility, which is going to give you that what I was talking about earlier, where hey, how do I do all this monitoring? So that's another level of training that you're affording.
Exactly.
Yeah, so that's good stuff. So how does this work? You have an online component, I guess.
We have an online component. We have probably about 32 hours of classwork that's online. We get right at the present way that we're running the course, we get on the Zoom 2 weekends and do that. We're considering switching that to where they watch the videos and then we get on them with them on a weekly basis to answer questions and the like. But we give direct feedback so that they can learn the materials more thoroughly.
And there's no difference from a regulatory standpoint, whether it's in person or Zoom for this part of the training.
For virtually all states, correct.
Okay, great. And how about the patients? And I know there's probably other programs around that folks can look into if they're interested in this kind of stuff. But with your program in particular, do I have to bring my own patient there, or are you guys supplying the patients, or how does that work?
Again, we're based in Kentucky. Kentucky will allow charitable dentistry to be done. So if you're not don't have a Kentucky license, you can get a charitable license, and then we screen the patients. We have them ready to go. We encourage but don't require doctors to bring their dental assistants so that they can know how to be able to help out. We have an optional program, whether you do our IV program or not, for dental assistants to learn the monitoring, if state allows, learn the venipuncture, and be able to better assist during IV procedures.
And how many hours is that hands-on again? Is it is it number of cases or hours?
It's number of cases. It is 20 cases. We spend 4 clinic days to be able to get it done. We run on the weekends, so that there are advantages either way. We don't run a come 1 week and do everything at the same time. For me, the extra travel cost to go one extra weekend versus having to miss an entire week of production in the office, to me makes more sense to make the couple of trips, and that's how we do it. And
Yeah.
Dr. Greenwell and I both practice full time. We do the whole week, and then we make it to his office in Radcliffe, Kentucky, and do the charity clinic on Friday and Saturdays.
And the folks that come in for your training, when they're not, let's say, treating their own patient, do they have the opportunity to observe and watch what's going on for the other participants?
They're all actively involved all the time.
All right, good stuff.
Okay.
And what about you mentioned bringing you can bring your own assistant, and in fact, you encourage that. So that's really great. I love the idea of having the staff in and staff training, and so on and so forth. What about pedo versus adult? Do you do is it a
Good
combined
question.
program, or do you have to have that different? I'm imagining these are two different things.
This is a program for, quote, adults, which is by definition age 13 and older. The criticality, the difficulty, the potential for problems goes tremendously up in children because of airway issues. It's all airway issues. And the chances of getting in trouble goes tremendously higher in children. So the guidelines for that the ADA provides are entirely separate for pediatric. My opinion, it needs to be done by the pediatric stuff needs to be done by a specialist, pediatric dentist, etc. And almost all of that is shifting to a hospital setting because of the potential for a catastrophic event.
And I think a lot of what we read about are pediatric cases gone
Yes, it
awry.
is. Yeah.
And I think that's yeah, that's important. And so I'm assuming you develop there are developed and you go over extensively in your course the criteria between there must be ASA classifications of what you should be doing and what you shouldn't be doing.
I stress the ASA classifications and MET scores, metabolic equivalence. If you understand those two concepts, you can keep yourself out of a lot of trouble.
Yeah, and then of course there's so uh, um basic course, and then I'm assuming there's recertification and advanced courses that are also necessary.
If you learn IV moderate sedation, you have to have some extra continuing education requirements. They vary from state to state. Uh, Virtually all of them now require advanced cardiac life support, ACLS, that you have to recertify every 2 years. Virtually all of them require at least 4 hours or more of additional CE.
So I was going to ask you about ACLS, and is that a pre-course requirement for your course, for instance, or is that something that you could take your course and then you got to go out and get before you can go for your certificate, if you would?
In our course, we just include it, period. It does not count toward those didactic hours, but we include it to make it easier on the students. May I talk politics for a second?
Sure.
I was, uh, when I was leading up to serving as president of the State Dental Association back in 2011, our state dumped the entire State Practice Act and had to start all over. And with that, a year later, all of the regulations had to be rewritten. I was on the track getting up to be president in a couple years of the KDA, and um, the state board did not have anyone that wanted on their board to even fool with the regulations. I told then president that I would be glad to serve on a committee if he'd give me a balanced committee, two oral surgeons, two GPs, two pediatric dentists, two periodontists. He made me chair, and bottom line, long story short, I principally penned the regulations for Kentucky that lasted for 10 years. Um, eh, but getting to the bottom of the story and honestly the complaint, we realized then that ACLS, there's so little of it you can do in a dental office that we did not require ACLS, but we required something hybrid in between. ADA in 2016 started requiring ACLS, and I think it was a political decision. I really wish that general dentistry would create a course that would meet someplace in the middle that are what moderate IV sedation dentists need.
So BJ, as if you don't have already too many things going on, that might be a good project for you.
It also requires a lot of political pull. Your help would be appreciated.
Yeah, so of course I'm always willing to help. So but I think that's really great that ACLS is actually included in your course because that's another weekend or two or whatever the case may be that you would have to go. And the fact that that's included, I think, is great. That's really good stuff. How long? So realistically, how long could someone expect this type of training to take?
We spread 5 weekends over usually about 4 months. Um, of the I When I'm lecturing, I give a bunch of support articles, usually PDFs out of the American Dental Society of Anesthesiology. I had one dentist I saw in our first course ever come in and printed them all out, and they're reference articles, okay? They're not meant to have to study detail, and they had a binder that was literally 4 inches thick, I think.
Oh
Uh,
my gosh.
uh, uh, we use Malamed's sedation book as our quote Bible. We require them to buy that in an ACLS book, and the rest of it we've all got included in our course.
Fantastic. And um, it's my
I,
understanding.
and I'll interject. One other thing that I would want to know as a dentist is how much is this going to cost me to implement over and above the course? And of what I hear from most of our students, as of 2025, when we're recording this, about $10,000.
And that would include things like pulse ox and different, like some of
Yes.
the, what are some of the things that
Yeah,
investment wise that,
the pulse oximeters, the equipment to be able to administer the IVs, your drugs to be including emergency kit, uh, emergency supplies, ways to be able to do an emergency airway, things of that nature.
yeah, that's fantastic. So on that note, I know that we mentioned earlier that you're the CEO of Stream Dent Software, and we talked a little bit about this before, and this is an entire podcast that I want to have you back on to talk about because this is fantastic. But just share with me, I know you're a big checklist guy, and that's what Stream Dent Software is all about, creating checklists. So just real quick in a minute or so, talk to me about that.
When I first certified in IV sedation in 2009, I had a patient stop breathing on me. Um, there was no oxygen in the office, and I knew what to do to turn on the oxygen, tip the head back, and whatever. And I got so focused that the oxygen tanks were empty, I found out a minute later, that all I could think about was that and wasn't thinking about an ambu bag, wasn't thinking about reversing him. It turned out okay. I had the patient breathing in another minute and a half, and he was never in any danger. But that was a wake-up call, and I started implementing checklists. After I got into it, I read the checklist manifesto by Atul Gawande, and I finally created a product that we launched in about 2014 that are customizable checklists for running a dental office, not just for sedation.
Yeah. Wow, that's really good stuff. And I'm going to have you back to talk about that. And I also want to have you back to talk about dental emergencies because I think that's obviously so important and you've got such great knowledge on that that I think that's going to be a great discussion. So share your contact information for there's a couple things for folks that might be interested in taking your course, as well as maybe having you come out and speak because I know you do a lot of speaking. You do a great job with that. You're in high demand there for that, or someone who just might have an additional question and they want to reach out. So how can we get a hold of you?
Okay, the IV sedation training program is IV sedation training for dentists.com. Pretty easy. My email is dr.m, Dr. Moorhead, dr.m at streamdent, streamdent.com. And I'm going to give you a Google Voice number that rings both my office and my cell phone number, so you can get a hold of me pretty much night or day. That's 502 509 1570.
And I can't let you off this call without asking you about the added bonus for being an AGD member.
Ah, uh, when we started the program, the Kentucky AGD sponsored us before we had our Kentucky PACE certification. And in exchange for them agreeing to do that, and we were going to keep it up, uh, if an AGD member joins, they receive a $1,000 discount on our tuition.
That's fantastic. And
Even if a dentist is not a AGD member, they can join the AGD and then still net $500 a head.
see that? Well, thank you. We really appreciate that. And you know, BJ, loved talking to you. I'm going to have you back because I want to talk about medical emergencies and some of the other great things that you have to offer. We just don't have enough time for that. So really appreciate you coming on the program.
Thank you, George.
Yes, and I'd also like to thank our producer, Kristen Gover. If you like what you heard, please like and subscribe to our channel. You can always find us on the AGD app, SoundCloud, Spotify, and Apple Podcasts. And if you have any questions, concerns, comments, or suggestions, contact us at news@agd.org. Thanks again, and we'll see you next time.